Hello, everyone. Just waiting another minute or two for some people to hop on. Thanks, y'all, for coming. If you want in the chat, let me know where y'all are from. It'd be great to know who's out there listening. And then we'll go ahead and get started here in just a minute or two. All right. I'll go ahead and introduce myself. My name is Liz Espinoza. I'm an acute care PMP out here in Portland, Oregon at Oregon Health and Science University, where I work in the PICU and I teach in the acute care program. And prior to coming here, I was a PNP in the cardiac ICU at the University of Iowa. So I am going to talk a little bit today about myocarditis. I was asked to do this talk for American Heart Month, and I talked to some of my colleagues in pediatric cardiology to try to decide on a topic that might be interesting and important and maybe not talked about enough. And the topic that kept coming up was myocarditis. And I think a lot of the reason that was coming up was because we've been seeing more of it associated with COVID. I know the cardiologists have said they've been seeing some more signs of some possible heart damage potentially related to COVID. And then also that it's just such an insidious diagnosis that oftentimes isn't talked about very much, but when it occurs, it can be pretty serious. So it's important to be aware of and kind of keep on your differential. I tell my students, we're a dual program, and so I tell my students, you definitely want to keep your differentials broad. And if you have suspicions for myocarditis, you definitely want to make sure that the patient gets some follow-up. So why is it a challenging diagnosis to identify? Well, the presentation is kind of all over the place. It can vary from pretty minimal symptoms to fulminant heart failure. Patients can be having life-threatening arrhythmias, or they can present all the way in cardiogenic shock. So it has this really wide picture, and that can be really tough because it can also look like a lot of other things initially, and then it can progress really, really quickly. The incidence in children varies with age. So we see peaks in infants and then again in young adults. And so those are the ages that I think to really be aware. And some of it makes sense because so much is viral related. And so we know those infants oftentimes are really prone to viruses and then again in young adults. And the patient course also is very variable. So patients can come in, they can have heart failure and just really quick spontaneous resolution of their symptoms, or they can go on and require a heart transplant. So it really is very unpredictable. It's difficult to identify. And even once it is identified, it can be really difficult to treat. The thing for PNPs to know, especially, is I think there are some distinct characteristics in children that are different than in adults. And so it's important to be aware of these, especially if you're working in primary care, in the clinic, or in the emergency department. All of these places where it could potentially be on your differential. And again, this is so important because even more, I guess what we call mild cases, but any case can lead to irreversible heart damage. And for children, this can impact their lifelong health and their lifelong heart health. So it's really important for us to identify these cases and make sure these children get treatment. There is some thought in the adult world that some of the idiopathic cardiomyopathy that they see in adults is actually from untreated myocarditis as a child. And I've also, talking to some of the cardiologists, that's, I think, a concern now with potential, if there's heart damage from COVID, that potentially we'll be seeing more heart damage as children age and become adults. So what is myocarditis? What does that mean? Well, it's basically as it sounds. It's an inflammation that develops in the myocardium, or that middle muscular layer of the heart. And this weakens the heart. It can affect the electrical system. And so that's why arrhythmias are common, all types of arrhythmias, atrial, ventricular arrhythmias. And both of those things can lead to heart failure. In terms of causes, infectious causes are thought to be the most common. So in viral myocarditis, the virus is able to enter the cardiomyocytes and the endothelial cells. And there are a lot of viruses that are potentially associated with myocarditis, and most of the common ones that we see. So Coxsackie virus, A and B, adenovirus, influenza A and B, hepatitis B and C, HIV, the herpes viruses, so CMV, EBV, parvovirus B19, RSV, measles, mumps, rubella, varicella are all associated, and hopefully our children are vaccinated for those, but there are many children, as we know, that are not, and so that is also a risk for developing myocarditis. And again, we've seen this not only associated incidents with COVID-19, but then also when we were seeing the MIS-C, which is similar in that it causes the ventricular dysfunction in children along with the shock presentation. So as you can see, there are many common viruses that have this potential to cause myocarditis. Myocarditis can also have bacterial causes, and some of the more common bacteria are strep A, staph, and mycoplasma, so things that we see regularly in children. And then there are fungal and protozoal causes that have been identified as well. We also know that myocarditis can be caused by an autoimmune response. We see this more frequently in patients with a family history or a history of autoimmune disease, such as patients with lupus. And then in those patients, or if we're suspecting autoimmune myocarditis, those patients often have symptoms of pericarditis in addition to myocarditis, which can also be associated with some of the viral causes. We were seeing a lot of that with COVID-19 as well, but that is something to think about if you're concerned for a potential autoimmune myocarditis, that they may have more symptoms of pericarditis alongside of the symptoms of myocarditis. And then on top of that, hypersensitivity to certain drugs and toxins can also lead to myocarditis. So it's really important to think about what medications your patient is taking regularly and if they are potentially associated with the development of myocarditis. So how do these patients present? Well, a viral prodrome is present in approximately 2/3 of the patients. So a lot of times it looks like just viral symptoms. And often these patients will present a time or two before with viral symptoms, potentially, fever, cough, respiratory symptoms, shortness of breath, potentially nausea, vomiting, diarrhea, but may seem very mild at the beginning. It may just be the virus, or but then maybe they'll come back again with the same symptoms. Arrhythmias are also frequently present. As I said, they can be ventricular, they can be atrial, they can be a high-grade AV block. So that is definitely something. Arrhythmias are a sign of a potential quickly worsening myocarditis. So if you have a patient that has some of these symptoms and is also complaining of palpitations or arrhythmias, it's definitely someone that you want to be seen and checked out. Fever is often present about half the time. A very small percentage may present with syncope. And then myocarditis has also been found to be a cause of sudden cardiac death in adolescent athletes. So sometimes when we hear about the athletes, the football player that suffered a sudden cardiac death on the practice field or whatnot, in the biopsy, they will have found that the patient had evidence of myocarditis. But overall, just the whole variety of viral symptoms, your typical viral symptoms. On exam, these patients often are tachycardic, maybe tachypnic, with some degree of respiratory distress potentially. Hepatomegaly may be present depending on LV dysfunction in approximately half of the patients, so definitely important on physical exam to check for hepatomegaly. About a quarter of the patients will present with a new murmur or a gallop. So definitely listening to those heart tones and definitely with a gallop and potentially a new murmur, being concerned for the cause of that and keeping myocarditis on your differential. Very rarely edema or cyanosis may be present, but it can occur. And oftentimes, if there's further workup, a poorly functioning LV is discovered. So, if the patients are sent in to the emergency department and a workup is done, it may be discovered there on echo. Cardiomegaly may often be discovered on X-ray. So, if potentially you're thinking possibly some sort of pulmonary issue or pneumonia, oftentimes you may then find the cardiomegaly. I actually lectured today on shock states and had the x-ray of one of my myocarditis patients who had been sent for an x-ray by their PCP and had a very, very large heart and a lot of pulmonary edema, and was sent straight to our center and put on an assist device. So that is one way that I tell the students sometimes. That's, if you have any questions, that's a potentially high yield, relatively low risk thing that you might want to consider in those patients. And then patients with fulminant myocarditis will present in cardiogenic shock to the emergency department. And this can often happen really quickly. I had one patient who just, again, viral symptoms, flu symptoms, not feeling well. This is a teenage patient, and got out to the car, drove 15 minutes to the hospital. And as the mom was getting him into the wheelchair to go into the hospital, suffered a full cardiac arrest. And so had gone from being relatively okay to in full arrest very quickly. Patients often, as they present rapidly to the hemodynamic compromise, it's important, again, to recognize these patients early and just be thinking about, could this potentially be something that's going on? Even though it is rare, it is out there, and it's really important to think about. So patients in the primary care setting, if there's suspicion for myocarditis, they should definitely be referred to the emergency department, probably for admitting and close cardiac monitoring, and a very low threshold to transport to a pediatric heart center if the need for mechanical cardiac support is suspected. These patients can be very difficult to transport if they're coming from a non-heart center, depending on how far away your heart center is. And so early transfer is an important consideration. Both places I've worked now and in Iowa, we were the transplant center in Iowa, but here we are not. And so it is definitely a consideration that we think about trying to get these patients out before they potentially need a mechanical circulatory intervention such as ECMO or a vascular assist device, something like that. But it can be very difficult to find a team that can transport the patient once they're in that degree of failure. Saying this as a former transport nurse as well, it's a very difficult patient to transfer. And approximately a quarter of patients that develop myocarditis are going to need some type of mechanical cardiac support, generally ECMO, because oftentimes there's spontaneous return of function. And so these patients are able to come off of support, but if not, they may go on to need some sort of more permanent ventricular assist device, or even be listed for heart transplant. And it's really hard to know from the beginning which of these patients will have spontaneous recovery and which patients will go on to have further heart damage. So definitely considering early mechanical support is important to consider, especially in patients who present with severe LV dysfunction, because the earlier we can decompress that LV, that can help maximize their chance for recovery of function. And as I was saying, the presence of arrhythmias is really concerning for a poor early outcome, and that's why early cardiac monitoring is critical. So if there is concern and the patient sent to the ER and there's arrhythmias found there, it's definitely reasonable to admit that patient just for some telemetry and monitoring to make sure that the diagnosis is ruled out. And then, so on to the diagnosis part, which is somewhat of the difficult part, because unfortunately the accuracy of testing remains an issue in the diagnosis of myocarditis in pediatric patients. So previously, endomyocardial biopsy was required to confirm the diagnosis. However, this has very low sensitivity. So even in the presence of a positive biopsy would confirm, but oftentimes the biopsy was negative, and so that would not rule out the diagnosis. And oftentimes these patients are really sick and maybe not in the place to go and have a biopsy at the time that they're admitted. So as we've improved our imaging and had all these advances in diagnostic imaging and cardiac imaging. Cardiac magnetic resonance imaging, so cardiac MRIs, are now being used more frequently, but with the same caveat. It can be used to help confirm a clinically suspected diagnosis of myocarditis, but it doesn't rule out the diagnosis of myocarditis. And at times, these patients are too unstable to undergo either of these types of testing, not infrequently. And so the diagnosis can still be made if it's clinically suspected. So in terms of the workup to look for other things associated with myocarditis, EKG definitely on all patients. You may see sinus tach. They may have non-specific ST changes. They may have ST segment elevation. You may see T-wave inversion. Low voltage QRS is also quite common, and then AV conduction delays. They also should have an echocardiogram, and so the most common finding on the echo is some type of global left ventricular dysfunction. So definitely often have low function. You may see a thickened myocardium, pericardial effusion, or some valve regurgitation. And then labs aren't used to confirm the diagnosis, but they're more used to trend, and so to help trend the degree of heart failure in the recovery. So you do want to send all the viral studies because a positive PCR may, again, help to confirm your diagnosis, but not necessarily. If you can send viral tissue PCRs, that's more specific. And then you want to look at inflammatory markers like CRP, and then trending your NT-proBNP and your troponins to help to trend your function can be very helpful for looking towards prognosis and recovery, but again, does not necessarily make the diagnosis. So oftentimes the diagnosis is made just on the clinical suspicion and the picture on presentation, depending on how sick the patient is. So in terms of treatment as well, it's very similar. There's the general treatment is supportive care. So supportive care for acute heart failure, supportive care for the low cardiac output. So often these patients are started on milrinone as first-line therapy, or if they present with cardiogenic shock, they may be started on epinephrine drip if they're very hypotensive and have cardiogenic shock. Often calcium may be given to help stabilize myocardium. And then again, there's low threshold for mechanical circulatory support. Other therapies are used, but the evidence is really mixed. So, and a lot of it is center dependent. IVIG is one therapy that's commonly used, although the evidence is very mixed, and so I think it's very center specific whether or not they're going to use IVIG. Steroids are another one that has potential, but again, the evidence is mixed, and so it just depends on the center and the transplant cardiologist there, and case by case basis as well. So those are some things to definitely think about in terms of treatment, but overall, the majority of the treatment is just supporting the heart and then watching for the regain of function. Again, if you find a bacterial cause, you're going to treat the bacteria. If you find a viral cause and there is a viral treatment, you'll treat the virus. So treating anything that you find as a potential contributor. Again, if it's a potential medication cause, you're going to want to try to stop that medication or change that medication to something else. So after these patients are identified and they recover, hopefully, they still will need a lot of follow-up and careful considerations. So they need regular follow-up with cardiology. They need regular echoes, EKGs, and cardiac labs. The majority will be sent home with a regular heart failure regimen of medications to help with the LV remodeling. and the myocardial remodeling. And again, evidence is really mixed on how long to continue those. There is some evidence that patients, again, that have myocarditis, children will still present with worsening heart failure as adults. And so that's why the close cardiology follow-up is really important. Approximately half of patients with myocarditis will have persistent systolic dysfunction that's present on echo. And then about another 20% will require heart transplant within 3 years of diagnosis. So again, that's why it's really important to watch these patients very closely. And then another thing to think about in terms of exercise is that these patients really need to be watched closely for sports participation. And if you're doing sports physicals or thinking about sports, definitely questions to ask to ensure that there's no history of myocarditis in their history. And again, I think talking to some of our transplant people, that the concern is that if it was mild and not recognized, like secondary to COVID or something, that these patients could present with sudden cardiac death, because sudden cardiac death is associated with a history of myocarditis with exercise. So again, if it was a patient that had a history and even regain systolic function, they are still at risk of sudden cardiac death with exercise. And so these children should not participate in any sports if there's active inflammation present. So still monitoring all those inflammatory markers and the cardiac markers, and really being careful about return to sport. So it shouldn't be approved until all your myocardial injury markers have normalized. Hopefully the inflammatory markers have normalized. So generally at least 3 to 6 months post-diagnosis, and often longer. And prior to return, all athletes need to have a full cardiac workup. So an echo, looking at their ventricular function, a 24-hour Holter to make sure that they're not still having arrhythmias, and then do exercise stress testing. So very important to help prevent sudden cardiac death in these patients. But otherwise, children that are followed and are on their heart failure medication, many of them do regain full systolic recovery and go on to lead long and happy lives and heart healthy lives. But it's so important for us to recognize these things and to be aware that children can and do get heart related disease, and that we need to be mindful of identifying these patients early and getting them to their appropriate treatment. Questions? Personally, so the myocarditis associated post-COVID-19 vaccine, great question. And actually, I should have looked up at the most current literature. So I've only seen one. I actually believe we saw one of the first ones. It hadn't been identified yet as a thing. The only risk factor and the only thing that we could find was that the patient had recently had their COVID-19 vaccine. However, there is an association, although small, and this patient actually had very quick spontaneous recovery, so was fairly ill, but didn't require mechanical support. Had some epi. I don't remember that he was even intubated. I can't quite remember. May have just been some non-invasive support, and did have a fairly quick recovery with full regaining of dysfunction or full function. And the last I had heard with the literature is that it was more common in teenage boys because of the interaction with testosterone. However, I myself actually developed myopericarditis when I had COVID about a year ago. And the thought from my physicians was I had just had my COVID vaccine and then was exposed several days later. And it seemed like an overactive immune response that was causing all of the symptoms. So I think it's something we definitely need to keep looking at. And like I said, I haven't looked at the data on that for a bit, probably a year or two. And so I'm not sure how much we're still seeing it now that most people have been exposed as well on their own. But definitely was an interesting case. Like I said, our team did not think that could possibly be the cause. And then I think about a week later, the cases started coming out, and they started drawing those pieces together and seeing that there were multiple cases of teenage boys that were having these reactions from the vaccine. Great question. Any other questions? Well, thank you all so much for joining. Um, it was my pleasure to be able to present this talk, and hopefully you've all had a good February and a good Healthy Heart Month, and I appreciate your time. Feel free to reach out if you have any more questions. Yes, I have recovered, but it took a long time. It was about 6 months. So um, it's definitely out there. And I think everybody needs to be aware, because I will say I also had difficulty getting diagnosed because the adult providers where I am at in a small rural town in Oregon had not seen it before. And so, it was an interesting thing. And of myself, having come from a heart center and having had seen a lot of this, and a lot of MISC, and they had not seen as much out here in general of any of those things. So I moved right sort of in the middle of COVID, and it was interesting to see the differences between different areas as well. All right, y'all. Thank you so much. Have a great night.